All right, welcome back everyone for our next half of the afternoon. Just before we begin, just a brief housekeeping reminder for the questions that were unanswered from Tuesday. The answers to those are now available under the syllabus tab. If you click the plenary session syllabus slides, it'll be right at the top. It's labeled unanswered faculty questions answered. So those will be there. For the questions from yesterday, those we're hoping to have up by the end of the day. And then any unanswered questions from Friday, we're hoping to have up for you guys by Monday. So with that, I'll go ahead and introduce our next presenters. So we have Dr. Sharon C. and Dr. Shala Baharlo. Dr. Sharon C. is a clinical professor and associate dean for professional development at St. John's University College of Pharmacy and Health Sciences. She received her BS in PharmD from Rutgers University College of Pharmacy and completed an inpatient family medicine pharmacy specialty residency at Deaconess Hospital and St. Louis College of Pharmacy in St. Louis, Missouri. She previously served as a clinical faculty member in the Brookdale Department of Geriatrics and Palliative Medicine at Mount Sinai Hospital, where she was the clinical pharmacotherapy specialist on the mobile acute care for the elderly service. Dr. C is board certified in pharmacotherapy and geriatrics, a fellow of the American College of Clinical Pharmacy, and a fellow in the 21st cohort of the American Association of Colleges of Pharmacy Academic Leadership Fellows Program. Dr. C has served on the ACCP Board of Regents and the Board of Pharmacy Specialties, Pharmacotherapy Specialty Council. And then Dr. Shala Baharlo completed her residency in internal medicine at St. Vincent Medical Center in Queens. She then completed her fellowship in geriatric medicine jointly at the University of Rochester and the Mount Sinai Medical Center and stayed on at Mount Sinai as a clinical educator. She served as medical director of the Geriatric Psychiatry Liaison Service at the Mount Sinai Medical Center for the Geriatric Psychiatry Inpatient Unit from 2006 to 2008. In collaboration with geriatric psychiatry, Dr. Baharlo has successfully implemented IMPACT, which stands for Improving Mood, Promoting Access to Collaborative Treatment, an evidence-based care model for treatment of depression in outpatient practice within geriatrics practice. She's also been serving as the point person for the Department of Geriatrics and Palliative Medicine for the Clinical Decision Support Committee with Mount Sinai EMR system. Dr. Baharlo is the representative for the Department for the Meaningful Use Committee, and her national activities include serving as co-chair for the Geriatrics Task Force within the Society of General Internal Medicine from 2015 to 2018. Thank you guys so much for being here.
Thank you so much.
Thank you.
Both Dr. Baharlo and I have no financial disclosures or conflicts, and Dr. Baharlo has received honorarium from the following groups, but has no relevance to this presentation. So today what we're going to discuss are four objectives with regards to medication management. First, I'm going to show you and introduce a way for you to evaluate your patient's medications. And it's an approach that I've used with all kinds of learners, all my medical students, residents, fellows, and pharmacy students. So I will start off with that. We'll talk about making sure we pay attention to renal and hepatic status in our patients and how important that is for prescribing medications. We'll also discuss the guiding principles of multimorbidities when prescribing for older adults. And we're going to talk about deprescribing, which is something that we focus on a lot in geriatrics. So I'm going to start off with what I call a hierarchy of medication evaluation. This is a thought process that I put on paper into a streamlined approach to think about medications when you're looking at your patient as a whole. And so I've designed this like Bloom's taxonomy with the most basic information on the bottom. And as you go up this pyramid, it requires a little bit more complex thinking about medications. So this first level, I call this baby pharmacy, these first two levels. And the first level really is really pretty basic, which is the medication I'm looking at, is there an indication for that drug? So if you're looking at a drug, and we'll use the example of amlodipine, does this patient have hypertension? That's a very simple first step you need to do, is make sure there's an indication that matches the medication. The second level of this pyramid is dosing. And again, this is very basic. It's looking at that amlodipine 5 milligrams once daily. Is that dose appropriate for this patient's age, their organ status, their kidney function, any other conflicting disease states? As you rise up in this pyramid, you get to probably one of the most important questions you need to ask before prescribing. And this is the monitoring level. And so I always tell my providers is ask yourself the question, is there any reason why I should not give this patient this medication? By asking this negative question, you'll automatically come up with that short list of basically contraindications or major adverse effects, black box warnings. So asking this negative question is much easier than asking the positive question. Who should get this drug? Well, that could be a long list of possibilities. So it's much better and will help you avoid medication errors and prescribing errors by asking this negative question. And once you've reached this level, you want to look at appropriateness and standard of care. What's the gold standard? And what is most appropriate for this particular patient? So that means knowing what do the guidelines say, and looking at your patient. Now, if we go back to this monitoring level, if we use the example of amlodipine, 5 milligrams once daily, we've already gone through the bottom rungs. The dose is fine. The patient has no need for any dose adjustment. And then I'll ask, is there any reason why I should not give this patient amlodipine? That's going to force me to think about side effects. And I think, well, does this patient have edema, peripheral edema? They don't have peripheral edema, then so far so good. But once we get to this top level, is this the best choice for this patient? If I told you that the patient also has an ejection fraction of 20%, then really the most appropriate choice for this patient's heart failure and hypertension is probably an ACE inhibitor. So then in that case, amlodipine, if that's the only thing the patient's on, is not the best choice. So you really need to be thinking through all of these levels as you assess your patient's medications. And of course, throughout, you want to be considering any multimorbidities your patient has. So I'm going to touch briefly on renal considerations because this is very important when drug dosing in older adults. And I will just talk to you a little bit about the basics, which is, as you know, GFR is glomerular filtration rate. This is the best index of kidney function. And the best way to measure that is from clearance of filtration markers like creatinine or cystatin C. Now, the National Kidney Foundation recommends eGFR for calculating GFR in your patient. Now, it's important to note that creatinine clearance is not the same as GFR. In my next slide, I'll talk a little bit about why we're really moving away from creatinine clearance calculations and moving towards eGFR, because the gold standard now is eGFR, although pharmaceutical companies and the FDA is catching up to these recommendations from NKF. So in practice, the question is always, well, what do I use to determine my patient's renal function for drug dosing? Historically, we've all been using creatinine clearance, and you've all been trained how to use that. And you've probably also learned somewhere along the lines that using creatinine clearance to determine a patient's renal function really has many limitations. And I've listed some of them here for you, which is number one, that calculation was developed at a time when creatinine assays were not standardized. So there were different assays in all the different labs. So that was one problem. The second problem is that data derived from those creatinine clearance studies was based in 249 veterans. There were 249 white males that was extrapolated to the entire population till today is what we've been using. And this is back in the 70s. The other problem with creatinine clearance calculations is that those original calculations were based on total body weight. And we know now that through various studies that really reduces the accuracy of calculating somebody's renal function. And then the other thing that we've been doing in practice in geriatrics for a really long time, and I used to teach this a lot, was it was very customary to round an older adult's creatinine up to 1 milligrams per deciliter if their creatinine was less than 1. And we now know that there really is no data to support that. So these are various reasons why creatinine clearance calculation by Cockcroft-Gault has really fallen out of favor. Now, I know that hospitals, including Sinai, they still show creatinine clearance calculations in their electronic medical records, but many are now moving towards showing you the eGFR. On the second item here, again, the National Kidney Foundation is recommending eGFR being used for drug dosing, primarily based on the CKD-EPI 2021 equation. There are multiple equations that calculate eGFR, and NKF has recommended this 2021 calculation. I put this calculator here for you, and this is a very easy way to calculate somebody's eGFR. Now, the other important piece of information that came out from these updates is that it's important your renal function calculation is more accurate if you individualize it to your patient's body surface area. And when you get a chance to take a look at this calculator, you just click a button that says adjust for patient's body surface area, and you put in the patient's height and weight, and it'll calculate it for you. So this is now a recommendation because they know now that this is the best estimate of creatinine clearance in your patient for predicting medication clearance. So what you may see in your electronic medical record is eGFR, and it will show the units of mils per minute per 1.73 meters squared. That's the standardized BSA. So that's if you just thought everybody was the same. When you click the button and put in the patient's height and weight, you're going to adjust that for body surface area, and your units will then become mils per minute. So I just want to put that there as a starting point for you. Check out the calculator, and you can look at your own EMRs and see how it's been reported. But many hospitals are moving in this direction. The other thing you're going to see in some of your institutions is that cystatin C is also a recommendation to use in the calculations. Some hospitals are not there yet, but you're going to be seeing that coming down in the future. I've put the reference here for you for the most updated guidelines that just came out in June. So I'm going to start with a case to kind of put together the hierarchy and talking about renal dosing. But this is a 93-year-old woman who came to our clinic. She's got hypertension. She has reduced ejection fraction heart failure and diabetes. She's on amlodipine, sacubitril, canagliflozin, and metoprolol. And you can see her vitals here. And I've highlighted her renal function, her creatinine. So let's use the hierarchy of medication evaluation to assess her meds. And so the first step is to determine if there's an indication for all of these medications. And if you go through, the patient has hypertension, so amlodipine's good. She's got HFrEF, so sacubitril is appropriate. Canagliflozin, she's got, again, diabetes, and metoprolol, she's got hypertension and heart failure. Okay. So the indication is fine, But now you need to look at the dose. And when you drill down to this, when you look at canagliflozin, right now the patient's on 300 milligrams daily. But when you look up the labeling and you look whether you use LexiComp, your drug database, you'll see that you need to dose adjust based on eGFR. So this patient's eGFR adjusted, I used the calculator, was 37. And when you look at the package insert, there is an adjustment for the dosing. So in this case, canagliflozin must be changed to 100 milligrams daily. So it needs to be lowered. Now, you also have to think about hepatic considerations as well. And we know that in older adults, they have a reduced ability to metabolize medications, which I'll talk a little bit in a minute. But they have reduced liver blood flow. They have smaller livers. And just like for renal function, you know, if you look up a drug in a drug database, it'll show you how to renally adjust. There is also hepatic dosing adjustments as well, and that's based on Child-Pugh scoring. And so if you can recall, Child-Pugh scoring is dependent on bilirubin, ascites, albumin, and a host of other labs that will help you score the patient. And depending on what score you get, that's going to inform whether a dose needs to be changed. And that's all reflected in the individual package inserts for your medications. Now, this next point I think is really important for those of us in geriatrics, and that is understanding what's the issue with metabolism in an older adult. And at the most basic level, there are two kinds of first pass metabolism. There's phase 1 reactions and phase 2. In an older adult, their ability to do phase 1 metabolism is altered. It's reduced. That means any drug that undergoes phase 1 process, metabolism, their dosing is going to need to be adjusted. Phase 2 reactions, on the other hand, in older adults is intact. So for drugs that go through phase 2 reactions, you have no problems. You don't need to dose adjust. And I'm going to show you an example of how that applies in clinical practice. So let's say you have a 78-year-old woman who comes to the hospital for alcohol withdrawal. And as you know, we would use the CWA protocol, which is benzodiazepine based. So you activate your hospital withdrawal protocol, and you have the option of starting either diazepam or lorazepam. Okay. Now, which one should you use? And this is where it's important to know about these phase 1, phase 2 issues in older adults. So here in my hierarchy, I'm talking about who should not get diazepam. That's asking the negative question. Who should not get it? So what I want to show you here really quick is that diazepam, which is a long half-life drug, which is why we like to use it in alcohol withdrawal, it undergoes phase 1 metabolism. So, and it has an active metabolite that's renally cleared. This is going to be a problem in older adults because older adults, their phase 1 metabolism is reduced. So if you gave a patient, an older adult, diazepam, it's going to accumulate and you're going to get adverse effects from that. So it's safer. This is why you see in your protocols, if your patient has liver problems or older adults, you should use lorazepam because lorazepam undergoes phase 2 metabolism, which is totally fine in an older adult. So that's the rationale for when you see your two different choices, you're going to not want to go through diazepam because of the phase 1 reduction in metabolism. I want to switch gears here to polypharmacy. Polypharmacy is, you all are familiar with the problem of our patients have multiple medications, and this can lead to severe consequences, not only in adverse events, but costs, non-adherence, functional status, and falls. So there are many issues with polypharmacy. And I just want to remind you that in some cases, polypharmacy is totally okay. just think about your patient with reduced ejection fraction heart failure. They're going to be on 5 meds oftentimes, and most of the time that may be appropriate. So polypharmacy is not always bad, but it's something at the top of our list when we're assessing our patients in geriatrics. Now, in terms of strategies that can help you, when your patient comes to you with multiple medications, is definitely encourage your patients to bring in their meds so you can actually look at them, make sure they're up to date. You can see what's left in the bottle. You can determine adherence easily that way. Many of you will do home visits, and that's a great way to see your patient's home environment. You can also call the pharmacy, ask them, get an updated list, and make sure you reconcile and talk to your pharmacist and make sure that you're both on the same page. This is especially important if you're going to stop a medication in a patient. I know everyone's really busy, but if you can reach out to the pharmacy and let them know, or through your EMR, hey, by the way, we stopped Lasix in this patient, because oftentimes this is where errors happen. Communication it sometimes gets dropped. Encourage your patients to go to one pharmacy. This is often a problem because somebody might go to one in Florida at their vacation home and one here in New York. So you want to try to get a handle on, try to have one place that your patient goes to. If you're prescribing devices, inhalers, eye drops, anything like that, it's helpful for you to demonstrate how they work, and for sure have them come see their pharmacist to help them with that as well. But a lot of times patients walk out with a prescription and have no idea what they're supposed to do with it. And then I find sorting by problem list, especially in our GERE patients who have, 20 medications, to really organize your note based on that, which you do already, but to include those meds in there. I want to make a quick note on blister packs. Remember that blister packs, I have a picture here. It's like a bingo card, and they put all the medications in for one time of day. These are for chronic medications only. And so please note that when your patient is hospitalized, and if anything is changed in that hospitalization, that means that information has to be communicated to the patient and their family members and the pharmacy, because oftentimes the blister pack was just filled, so insurance just paid for it, and they're not going to fill another card because of the one change in Lasix dose from the hospital. So you would have to write a separate prescription for the Lasix for the rest of the month. So just keep that in mind, that communication is going to be really important with your patients with blister packs. I'm going to switch over to Dr. Baharlu.
Thank you, Dr. C. Hi, everyone. I will be speaking to you in terms of a couple of things. One is multimorbidity and how. Thank you. I'll be speaking with you in terms of multimorbidity. What is it? How is it defined? And how is it that going to affect your prescribing, patient's condition, and also the relationship between multimorbidity and disease-specific guidelines? As you know, multimorbidity is essentially defined as having 2 or more medical conditions lasting more than 1 year. I think we could easily say that many of our older adults would fit into that category. Now, how is this applying the disease-specific guidelines going to be relevant to patients with multimorbidity, having multiple conditions? We have seen that in practice, most of these disease-specific guidelines are going to be limited, particularly because multimorbidity brings in with itself multiple sequelae, and it could adversely affect how we are prescribing or how we're treating the patients. And in terms, it would affect patients' condition. One of the things that you could see, for example, is this disease, medication interaction. If we have a patient who has CKD and has heart failure and they have hip pain, for example, and they see their orthopedic physician who's unaware of these two conditions or perhaps not so aware of, these interactions, they might be prescribed NSAID. Commonly, this happens in practice, and you could see the NSAID on its own could worsen the CKD, as well as put patients at risk of exacerbation of their heart failure. That essentially would result into a poor outcome. There is also the effect that we call therapeutic competition, which is essentially starting a medication for a condition based on a disease-specific guidelines. Let's think about beta blockers for heart failure. We know how effective they are. However, if this given patient has COPD, they could have their COPD could get worsened because of this particular treatment. Now, there is also an element of efficacy versus toxicity, which is challenged by patients' life expectancy, because some of these medications that are going to be super helpful, and we have specific guidelines for them, including, for example, statins, they take time for showing benefit. And, having a patient with limited life expectancy could essentially put them at not being a candidate for this type of treatment despite the efficacy of this medication. So thinking about time to benefit, thinking about life expectancy and what is important for the patient, it's always into our equation. There is this altered clinical presentation. When you have more than one condition, people might not present exactly, with a clear-cut presentation. And as Dr. C alluded to, we do have decreased pharmacokinetic and pharmacodynamic with therapeutics with aging. So this could also change how patients would respond and react to any of these medications. Something to consider in your prescribing. Now, what is the way to interact with this? Do we have any guidelines? Do we have any type of things that could help us understand how we can take into account patients' multimorbidity, as well as their general condition, and when we're seeing them for a particular condition and we're doing the prescribing? American Geriatric Society in 2012 came up with a nice guiding principle for this group of patients. This was a result of a work group, expert work group, that looked at this group of patients and came up with these principles, essentially thinking about patients' preferences as well as interpreting the data, particularly when we know most of these data are not examined or researched or included older adults, thinking about patients' prognosis and incorporating perhaps tools like e-prognosis, thinking about treatment complexity and feasibility in that particular group of patients, with a lens on looking at medication and disease interactions, as we talked about, absolutely looking at benefit versus harm for these patients, and thinking about how can we optimize treatment and care plan with a close attention to tools that potentially can identify the inappropriate prescribing. Beer's criteria would be a really wonderful way to look at that. Also, there's a deprescribing group that is giving recommendation into that effect. Also thinking about mostly non-pharmacological versus as opposed to pharmacological intervention. And as Dr. C was talking about, thinking about perhaps those negative questions and maybe thinking about not starting. and stopping the medications when we're, starting to think about how to approach the patient. Also, always considering balance and balance of benefit versus harm for these patients, and thinking about what matters to the patient and what matters to their families. What are the things that they're considering, and staying in, keeping everybody in the loop, making sure all the members of patient's care plan, including cardiologists, multiple specialists, they're all on the same page. Now, this work group, they have gone and done even a much more impressive job in terms of creating this algorithm that I would want to share with you, that actually looks at applicability of this disease-specific evidence-based guidelines to older adults with a much more clear lens. Those guiding principles, I think, in general, give us a really good framework. However, this looks at patients' multimorbidity, as well as life expectancy and their function, and essentially puts patients in 3 different categories. So if you are seeing a patient who's functionally very fit, an older adult who's functionally fit and has a much longer life expectancy, more than 10 years, and they really have few conditions, those people, you could think of them as a good candidate for any of the disease-specific guidelines. They could benefit from that if it really is within their preferences. On the other hand, we have a group of people who have a very limited life expectancy of less than 2 years. These are people who have advanced and end-stage diseases, serious illnesses that are progressive, including dementia, heart failure, and cancer. In this category of patients, these disease-specific guidelines are not really applicable. And for this group, we ought to think about de-escalating the care and really thinking about symptom management, comfort care, and palliative and hospice approach. Now, what happens to this middle group, which is an uncertain group, which I think always is complicating to look at people who are, not so clear-cut, in terms of decision-making. These are people who have 2 to 10 years life expectancy. They do have multiple conditions, and they have increasing number of multimorbidity, and they are on a verge of, worsening function, which is a critical piece in this. So these folks, what do we do with them? This is when this group actually recommended, which I thought it was really smart, thinking about having a more clear lens of health priorities, aligned care, and thinking about what would be a really wonderful way of looking at their current care planning in addition to advanced care planning. Now, what do we mean by that? Essentially, for this group of patients, thinking about what is their health priorities, what matters to them most, thinking about what is their health trajectories. If they have heart failure, ejection fraction is 25%, we are not going to think about, 10 years down the road or 3 years down the road, 5 years down the road. So really thinking realistic expectation and thinking about their health priorities and trajectories, helping them decide on stopping. Think about the negative in here, which, in terms is actually beneficial for patients, starting or continuing some of the care based on these health priorities, considering benefit versus harm and their health trajectories, and making sure that the care is aligned and everybody is involved in this and every team member knows about this. Now, a good example of, the great example of showing benefit versus harm is this study, ASCEND study, that looked at the role of aspirin for primary prevention of any serious vascular event or revascularization in patients with diabetes. And if you look at this, you could see the number needed to treat was very small, so that's great. However, although the less event was 12%, but absolute risk reduction was actually really about 1%. Now, on the flip side of this coin, having a major bleed with this primary, prevention, with this prescribing for primary prevention was actually really high. It's about 30% of patients had more bleed. So this is something to think about when you're looking at the guidelines for evidence-based. Also, if you think about the time to benefit, and if we look at the patients with HFrEF or heart failure with reduced ejection fraction, we could see that if we look at the outcome of all-cause mortality over time, on the surface, these medications are all great, including the new kid in the block of SGLT2 inhibitors. However, when the number needed to treat for all of them are very small, they're very effective. However, if you look, most of these medications, or all of them, they actually take at least a year to start showing benefit. So it's important when we have a 90-some-year-old who is now newly diagnosed with heart failure, ejection fraction of 25%, and we are discharging them out of the hospital, and we are putting them on any of these medications, including the SGLT2 inhibitors, thinking about what's the life expectancy and whether this person could benefit from this. Just wanted to make sure, we're looking at one aspect of this outcome. Sometimes some of these medications could help with symptom improvement, so that could essentially, show the benefit even in people who have lower life expectancy. With that, I'm going to let Dr. C talk about deprescribing.
Okay, let's switch gears to deprescribing. There's really a couple of considerations you need to think about with deprescribing, which is trying to determine whether or not you should stop a medication. And so you need to look at those basics. Drugs that have no indication, drugs that are more harmful than good. What does your patient want? What are their values and goals? And again, it's so important to know about time to benefit and certainly life expectancy, because you need to know if they're going to live long enough to benefit from the medications. This is one good resource for you when looking at deprescribing. It's the Canadian Deprescribing Network. But some classic drugs that we look for in our patients to really see if they absolutely need it. PPIs are very famous. Many people are on PPIs that really don't need to be. And so you'll want to look at this list and really assess whether there's a true indication for these drugs. So antihyperglycemics, antipsychotics, benzos, memantine, and those sedative hypnotics like the Z drugs. So let's move on to a case. So this is an 88-year-old patient who we saw in the hospital with severe neuropathic pain and with type 2 diabetes, and he was only on Tylenol at home. You can see he's got CKD5, heart failure, CAD, hypertension, including his diabetes. He did have a history of gabapentin abuse at home. But in the ER, they gave him gabapentin anyway, and the patient developed tremors in the ER, so they stopped that immediately. So the patient's now on the floor, and we're trying to decide what to do to deal with his severe neuropathic pain. So I want to show you the important labs here, but you can see his pressure was up. His BON his BON and creatinine are 67 and 4.06. He's got a QTC of 555 and a creatinine clearance of At that time, we did creatinine clearance, so it was 8 mils per minute, but regardless, it's very low. He's got CKD5. So right there is a red flag for drug dosing. Now, I want to show you how we went through this thought process using the hierarchy. First is, who shouldn't get this drug? We already know he shouldn't get gabapentin. He got tremors, and he had a history of problems with it. Well, what about pregabalin? Who should not get it? Well, it doesn't matter because we don't have it on formulary. What about TCAs? Well, who should not get this drug? Older adults, which is him, and people with arrhythmias. He's got a QTC of 555, so not a candidate. Duloxetine, in the US package insert, we're not to give it with a creatinine clearance less than 30. So he's not a candidate for duloxetine. Morphine, he's not a candidate because of his renal function. So in this case, we have to use our clinical judgment. We used Dilaudid for him. He didn't have issues with respiratory depression, and it was okay. Doesn't need to be renally dosed. Next case is a woman with diabetes, came in for hypoglycemia. She was on, nobody really was sure what insulin dosing she was on at home. Last admission she was discharged with basal bolus insulin. In the SARS, she got Humulin 70/30. So we really didn't have a good handle on her. Endocrine came in and recommended Januvia 100 and Repaglinide 4. So when we saw this consult, this recommendation, my first question to the team is this the most appropriate regimen for this patient? And so you want to ask yourself, well, what's the current standard of care? What are the recommendations? So when you look at the ADA guidelines, we know that her current A1C is 6.5%. So what's her goal? So if you look at the ADA guidelines, we know that someone like her who has complex intermediate health status, she's got CKD, she has emphysema, depression, hypertension, that a reasonable A1C goal for her is less than 8%. And so she's already at 6.5%. So really she did not require any treatment. So remember, sometimes giving nothing is completely appropriate. And Dr. Baharlu, you want to finish with this case?
Thank you. Absolutely. Thank you. So let me talk. Sure. Thank you.
Go ahead.
Eugenia is our 84-year-old female who is admitted to hospital for altered mental status infection. Infection was ruled out in this case. She was, again, admitted for altered mental status. They didn't find any cause for it. She has history of MDD, anxiety, chronic pain syndrome, and progressive dementia, has been on pain medication and treatment of depression for a long, long time, several years. On day 2, she's at baseline AO and alert awake oriented time 2 to 3 with some forgetfulness. Then she starts having some persistent nausea, vomiting with abdominal pain on day 3. And on day 4, she's really sick with SVT. She has atrial fibrillation. It's resistant to treatment, requiring IV amiodarone. Again, prior to this, her medications were OxyContin plus oxycodone, duloxetine, mirtazapine, trazodone. They were all stopped upon admission because she wasn't able to tolerate PO. And she's been on these again for several years. She continued to have this GI and cardiac symptoms over the next 2 weeks. What do you think that could be possible cause of GI and cardiac symptom? Team was not able to find anything. They have done an extensive workup. Could this possibly be a discontinuation syndrome, withdrawal symptom, essentially from her opioids and antidepressant? So this gets us to this discontinuation syndrome that happens with antidepressant. There is a mnemonic for this. Finish. If you're good with mnemonics, this is for you. Flu-like symptoms, insomnia, nausea, GI symptom, vomiting, abdominal cramping. You could feel imbalance, also having sensory disturbances and hyperarousal. This usually occurs with antidepressants that are have a short half-life. What are the examples of that? Venlafaxine, paroxetine. They are, those are the things that could cause this. Those are good examples. It often happens when patients have taken these medications long-term. What defines that is usually more than 8 weeks. And the onset could be variable. It could be hours to a few days, and it could last for several weeks. So that's the confusing part. And the treatment to it is restarting the antidepressants. Now, in this particular patient, these were her medications. The take-home message on this is that if you look at this amongst, the antidepressant and the opioids, the onset of these withdrawal could vary really from hours to days, and it could last to several weeks. So that could create a lot of confusion and poor outcome potentially for the patient if it's not detected and appropriately treated. In conclusion, we want to leave you with the rationale for prescribing, which it's a process. It requires a thoughtful decision-making with a hierarchy aid that my colleague went through. Also, thinking about medication management in older adults is more complex even because of their multimorbidity and because of all of the elements that is with them. Providers really could benefit from using these guiding principles and the algorithm that I shared with you. It's also important to be aware of these withdrawal as much as we want to do deprescribing. Thinking about doing that also in a thoughtful process is going to be important. And thank you so much for giving us this opportunity. And we're opening it to questions, I think.
Thank you guys so much. I know it's a very broad topic to cover in a short amount of time. We do have 2 questions in the chat, but I think just to make sure that we stay on time, if it's okay, we'll just ask you guys to send us the answers to those, and then we'll disseminate them to everyone afterwards. Thank you guys so much.
Absolutely. Thank you so much.